Hello. Yeah, I think moving on from the relatively commoner podocytopathies and IGA nephropathy to the more aggressive and, as the name suggests, rapidly progressive glomerulonephritis section, we have Satish, one of my favorite speakers. I'm so happy to have him come to our discussion. Satish, over to you, taking us through.
Thank you, Dr. Umesh. Nice compliment. So, I think Dr. Raja opened this thing saying that you have a lot of evidence in membranous nephropathy. I am talking about a condition where you have practically no evidence. It's all opinion based. So, I'm also talking mostly about opinions. So, first of all, let us just define what is anti-GBM nephritis. I think you all know it. I don't have to talk about it. It's a small little vasculitis primarily, but it is by antibodies directed against the glomerular base membrane. It's a very simple way of putting it. And it's also against the alveolar base membrane, because 30% of patients have associated lung involvement, and many of the times it may be associated with ANCA vasculitis also, and clinically present as an RPG. That's the basic way by which we approach this condition. So let us see what's new in the pathogenesis of anti-GBM. So we all know it's directed by circulating antibodies against glomerular base membrane antigen, and which are usually IgG1 and IgG3, but rarely they can be IgG4. And they are typically polyclonal, but sometimes, very rarely, you can get monoclonal. These are completely different diagnosis and problems from looking at. And one of the unique things about this condition is that the antibody is short-lived and it doesn't recur after that. There has hardly been a case of recurrence in literature. Even the post-transplant recurrence is usually when the antibody is not completely from the circulation. So that is why the other corollary to that is that the disease is treated aggressively at the onset. Probably we should be able to get a complete response, and therefore we should be able to completely destroy. But that doesn't happen, because by the time the patient presents, usually there is some damage that's already occurred. So what is the target antigen in this? That the most important antigen is the alpha-3 chain of collagen, type 4 collagen. And this is the NC domain, that is the non-collagenous domain. And there is two specific antigens that are identified called EA and EB. EA is present in the amino terminal portion, and EB is in the carboxy terminal portion of the NC1 domain of the alpha-3 chain. And both these are cryptic epitopes. They don't normally be exposed, but they're exposed when there is some damage to the system. So there is some dissociation of these hexamers of NC1 domains which are there. And that dissociation is what causes the exposure of these antigens. But then there has been more study on what else happens in these. So there is something known as intermolecular and intramolecular epitope spreading which occurs, and therefore more antigens become involved. So the first thing what we already saw is that alpha-3 non-collagenous, but alpha-5 non-collagenous domain can also be involved in this condition. But some other antigens have been involved. One is laminin 521, if you can see here, as just shown there. And that laminin 521 is present in the glomerular basin and in close association with the type 4 collagen. And this has also been seen in about 40% of patients. And one of the things is noted that most of these patients have lung involvement also. So maybe that one of the epitopes spreading to this is causing the lung involvement in these patients. But then there are also other patients without this who also have lung involvement, so we cannot specifically say that this is involved. This is one look for lung involvement. And then there is this peroxidase. This is actually an enzyme which is involved in creating the sulfonyl-imine molecule, this SN connection between the NC domains, which actually keeps the NC domains together. And that bonding is due to this particular enzyme of peroxidase. And peroxidase is the target of these antibody forms, and that has also been known 40%. So, and lastly, there is another thing of entactin, which is a molecule which actually binds the laminin and the collagen type 4 together. And anti-entactin antibodies have also been shown in these conditions. So, the important that peroxidase, one of the things is that it actually has an association with anti-MPUH. In fact, it behaves like an anti-MPUH, and sometimes it can be mistaken for anti-MPUH antibodies in these conditions. And the other portion of that is some of the anti-MPUH antibodies in ANCA vasculitis actually target peroxidase. So it goes both ways. So it may be one way of connecting these two diseases together. You can see that there are a lot of patients with double POC, and one of the reasons is because. So apart from the direct antigen-antibody interactions, there is of course complement. Complement is there everywhere. Complement is there here also. So complement activation by both classical and alternative pathways have been noted in anti-GBM, not lectin pathways. And then there is the role of T cells. So autoreactive T cells have been shown. Now we think that it's probably a B cell mediated or a plasma cell mediated disease because of a lot of antibodies. But autoreactive T cells also contribute to pathogenesis, and they have been demonstrated in these cases. And on the opposite side, the regulatory T cells have been shown to be protective. So in course of time, people develop regulatory T cells. That will be the mechanism by which you actually, the disease gets remitted, and therefore, because of the persistence of regulatory T cells, maybe you don't have a subsequent disease. That's one of the postulates why the disease doesn't recur, and why every other antibody, maybe you have membranous, they all relapse, but this doesn't relapse. And how these autoreactive T cells work, one by activation of B cells, but they can be directly toxic by themselves without using these B cells. So having talked about pathogenesis, little bit about epidemiology, we know that there is a bimodal distribution in second and third decade as well as sixth and seventh decade, but incidence is very rare. So fortunately, it's very rare because it's a very severe disease. We don't want to see more of it. So it's about 1.5 per million population. In fact, look at rare disease. Actually, I was recently listening to a lecture by J. Radhakrishnan and on IGA Nephropathy, and he diagnosed that as a rare disease. So you see that is a rare disease, but it's a very rare disease. And then you have, there are some associations with this. One is inhaled hydrocarbon and smoking. It's very easy to see that this can actually damage the lung membrane. Why that predisposed to kidney disease is not very common, but patients who have exposure to these have much more higher incidence of lung disease, which clearly seems to be a association which can be explained by common sense alone. But infections like influenza and COVID-19 have also been known to trigger antigen disease in the kidneys and the lungs. So why this happens to these, we don't know. There are so many other lung diseases that do not prescribe, but these two do happen to be. So that's the problem with understanding the epidemiology behind this, and because the disease is rare, it's difficult to study. For the clinical presentation, the RPGN is the most common form of presentation, and you can see that over time, what has happened is that dialysis dependency at presentation has actually come down. In the series before 2006, it was almost 50%. Now it's nearly 30%. So maybe because we are detecting it earlier. Maybe because people are referring to nephrologists earlier, because sometimes what happens is that you see a creatinine and you just follow it up, and by the time you follow up, it's gone too far because it's so far. And pulmonary symptoms are seen about 30% of patients. So fortunately, that is also good because pulmonary symptoms sometimes they define the disease and patient may die before you can even treat it. Hematuria is almost always, microhematuria is almost always present, but macrohematuria is present in about 30% of patients. And if the patient has significant other systemic involvement like the arthritis, we should always be looking for other associated ANCA vasculitis, because by itself the disease usually affects only the lungs and the kidneys. Then there is a little bit of dual antibody. I'll talk a little bit about this later. It occurs in about 40% of disease. There is dual antibodies, both ANCA antibodies as well as anti-GBM antibodies. Usually in older age with more systemic manifestations, and one of the things, the relapses are more common in this disease, but that is because of the ANCA, not because of antibodies. What about serology? So what we are doing commonly is the ELISA test, and that is an enzyme immunoassay against this particular antibody. This particular antibody which actually causes the antigen, which attaches antigen on the alpha 3 NC domain. But these antigens, what we are using is actually purified glomerular based membrane, either human or animal. That is what is being used for the antigen in these assays. So about 10% of these will be negative. So that means quite good, 90% is positive. But if you want to confirm, you can use Western blot. That is used only in research laboratories. It's not being used as a general practice. And there is a very, very sensitive biosensor assay in which they have shown. The biosensor assay is actually an assay in which they are actually doing an antigen-antibody reaction and seeing it. And this sensor even picks up those 10%, and there have been studies that have shown that anti-GBM can read them on this. But again, it's not of much clinical relevance. You see a biopsy with linear IgG, and then you see that there is an anti-GBM there, and you have the clinical presentation. It is almost diagnostic. So this will only be helpful if it is. If it is negative also, it doesn't really matter. You can always treat it as an anti-GBM disease. So the pathology, there are some nuances in pathology you should understand. One is crescentic GM is a rule, and almost 70% or 80% of patients have more than 50%. Number of crescents correlates to renal impairment. 100% crescents, very rarely they recover. Almost always they go in for NC there. And as we all know, typically the crescents are the same age, so they'll be either cellular or fibrocellular or whatever. Then you can see fibrinoid nephrosis in both normal glomeruli as well as in the crescentic glomeruli. And in early stages, you can just see segmental proliferation and you can have exudation, that is neutropenia. So in early stage, it may present that, but you can see the crescents even there. And rarely you can see actually periglomerular inflammation with even multinucleated giant cells and granulomas. And one of the characteristics, IGA usually does not occur in this disease because usually diagnosed early. and only the patients who you do not diagnose early stage and find out late, you can find IFTA. And IFTA, in every glomerular disease, IFTA is one of the parameters you are using to see whether this is going to be progressive or not. In this case, you don't use it. It's not really useful. And this is some of the pathologies you can see in this condition. The first slide. So this is the slide just showing some proliferation and not much of finding. Here you can see an early crescent. It is not circumferential, but here you can see a full circumferential crescent in this particular third one. In D, you can find that on the silver stain, the same type of crescent extensively, and you can see the glomerulus really crushed out there. And here you can see the basal membrane breakdown and the RBCs in the Bowman space. And lastly, you can see the same age two twin glomeruli together. So it is rather daunting to present in the front pathologist. So this is other conditions in which a linear IgG develops, which we also know and is useful for especially exam purposes. So in diabetic nephropathy, there is a weak IgG stain, but you can get a similar intensive IgG stain in febrile glomerulonephritis as well as in paraproteinuria, especially in MIDD and PGNMID. You can get this type of stain. But then it is not really confusing for us because you can easily make a diagnosis that this is not an anti-GBM disease. And then alveolar hemorrhage. So this should be easily diagnosed. But one of the problems is that many of these conditions, whether pulmonary hemorrhage, may be due to pulmonary edema or maybe due to some other factors. So in order to say alveolar hemorrhage, one is the X-ray and the CT are actually very contributory. You can see the X-ray here. It's showing bilateral infiltrative lesions which are prominent. And you can confirm that on a CT, which will show much better the alveolar hemorrhage. And you can see the hemocentrin-laden macrophages in the lung. And lastly, with the DLCO, which you are going to do, and you have seen that the DLCO will be increased because there is a carbon monoxide uptake by the RBCs in the lungs. So finally, about treatment. So one of the things about anti-GBM disease is that the treatment has been largely affected by one single trial published in 2001 from the Hammersmith series. So this was actually a retrospective series in which they published over the last 25 years. So for 25 years, they saw 71 cases of anti-GBM disease, and they stratified this into either the creatinine less than 500 and more than 500. And you can see that it's not that much different. So at 1 year, you can see that 95% renal survival in less than 500, about 80% in more than 500. And if they followed up these patients for about over the last 20 years, and they found that this came down to around 75% at 20 years, and this came down to 60%. So creatinine itself does not define, but what is most important is dialysis dependency in this slide. So you can see that 39 patients are dialysis dependent, and only 2 of them at the end of 1 year were off dialysis. And both these patients subsequently went on dialysis. And those 2 patients had predominantly 18, had a very large component of 18 on the biopsy compared to the other patients. So one of the things is when patient dialysis dependent will never come off dialysis in this condition. And that is probably one of the defining factors, and this has been shown repeatedly in different series over the years. So this is the KDIGO. I got a little excited and put it as KDIGO 2024 guidelines. Actually, it's 2021. But even if they publish a guideline 2030, I don't know whether it will be any different than this. So, because early identification is the key. And so you have to biopsy early or start flex. If you can't biopsy, start flex. That's if you suspect, just start flex immediately. So flex is the primary treatment. And you can find that all the data I searched, I found only one randomized trial, and that was on flex, and published in 1985 from the US. And actually, that trial did not show much difference. Those were flexed and not flexed. The only thing was that the antibody levels came down better with flex, which is obviously you would expect that to happen because flex actually removes the antibodies. So they did not actually, but then the most important factor of flex is the lung hemorrhage. That is going to make a big difference if you are going to flex in these patients. So the dosing of flexing is 50 to 60 ml per kilogram, maximum of 4 liters, and to be continued for minimum 14 days or till recovery. So minimum 14 days, what they say. Then you give IV steroids, and steroids will be tapered and stopped by 6 months. Cyclophosphamide, oral cyclophosphamide, what is suggested, 2 mg per kilogram orally, and maximum 3 months. IV cyclophosphamide is not recommended. You look at practically, what are you going to do? IV cyclophosphamide we are using regularly. In most of us, I think, are using, and it is reasonably good, efficacious. And usually we use the UOS protocol of IV cyclophosphamide, the 15 mg per kilogram every 2 weeks is what has been used. So rituximab has been used So the rituximab has been tried in different settings. It has been tried upfront as a first line management, tried as second line management, and cyclophosphamide has failed, has not given the adequate response, and it has been used in other contexts also. If you use it first line, it is not as effective as cyclophosphamide. That's what some of the trials have shown. They are all observational trials. There is no RCTs. The number of cases is too small probably to have an RCT. And the Plex trial which I told you about had 18 patients, 9 patients in Plex group and 9 patients in non-Plex group. So not really numbers by which we can make a lot of evidence. So rituximab has always been used along with steroids and usually used when cyclophosphamide was not tolerated or contraindicated. And then, so you can use rituximab as a second line agent and also as an agent later on. I will just tell you a little bit more about rituximab later on. All patients should be given co-trimestol prophylaxis, and also you should give calcium, vitamin D3 and other things, not supplements. And lastly, nowadays there has been a small trial on immunoadsorption, and they have found that 9 sessions of immunoadsorption using a column which takes up IgG, IgM, and also immune complexes is actually even superior to plasmapheresis in removing the antibodies. Whether there is a clinical response or not is a different issue, but it has been shown to be effective. So probably you can use immunoadsorption, but then the costs are much more than that of Plex anyway. Transplant, of course, is the treatment of choice for those who can say the only one point we have to know about transplant is that they should be negative, antibody negative, minimum 6 months, and at least 2 times you have to check the antibody and make sure that's negative over a period of 6 months. One of the things you can use is if the patient has this continuing antibody levels, you can use rituximab in order to reduce the antibody titers before transplant. It's very effective in that situation. So what are the newer treatment options? So one of the things which have been used is very with good drug and probably an ideal situation to use that is imlifidase. Imlifidase is IDES or an immunoglobulin degrading enzyme of Streptococcus pyogenes. So what this imlifidase once it gets into the body, it just remove all the IgG in the body is cut down into an FC and FAB fragments. So you don't have any IgG at all once you give that compound. And therefore you expect that anti-GBM antibody. So in the phase 2A trial they gave 10 patients who are all dialysis dependent. The 10 patients dialysis dependent and 5 patients with non-dialysis dependent with a high, with a very low EGFR, 7 to 14. They are all given imlifidase and all of them had anti-GBM levels dropped to 0 in 6 hours. So I think that's the fastest way you can get the antibody levels down, probably even better than Plex. So probably it may replace Plex if it's available in large quantity. At 6 months, you can see that 10 out of 15 patients are off dialysis. Now that is a response which has not been seen in any other therapy so far. 10 out of 15 patients are off dialysis. So probably imlifidase has got a good bargain. Now you can the imlifidase can be given only once. We develop antibodies against that, and second time we give it is not very effective. That's what has been seen in the transplant trials which have been done with imlifidase. So hopefully we need to give it only once anyway in this condition. Then what about rituximab? I just wanted to say something more about rituximab. It's all small trials. All the trials rituximab, I think the biggest trial rituximab actually calculated a series, and that whole series contains 75 patients. All the analysis of all the previous trials. So most of them have shown efficacy, and the two situations what we use is one as a second line agent where it is really effective, better than giving cyclophosphamide alone. So you can supplement with rituximab. And lastly, to get rid of antibody before transplant. These are two situations where you can use rituximab. But as an upfront molecule, probably cyclophosphamide is still superior to rituximab. And what are likely therapies which are seen? So in the middle you can find these are therapies already there. That is plasmapheresis, rituximab and cyclophosphamide, corticosteroid, MMF. I don't know whether anybody will use MMF in this condition. We don't need to use it long enough because all the immunosuppressants are going to stop after. But you can have antigen agents targeting thrombin generation because fibrinoid necrosis and fibrin is one of the key events here. But again, I don't find much future for this type of treatment. And anti-inflammatory cytokines, again, it's a very disease that's so fast. So I don't know whether this is going to be really helpful. When antigen epitope modulating agents are there, they are still in that experimental stage, not even reach animal trials. So it's too early to make a statement regarding, but they do seem exciting. Agents modulating HLA. So that is because one of the features they have shown that there is definitely HLA modifiers. There are some HLAs which actually are protective. HLA DR2 is shown to be activated with the disease. And so probably if you have an HLA modifying the antigen presentation to the cell, it may be effective. But again, these all look very far down the lane. So only one therapy which we do have now is IgG degrading enzyme, which may be effective. If it's probably cheaper, we may be able to use it in the future. And what are the predictors of disease progression? So this is also very interesting. So that's what It's different from usual glomerulonephritis. What is the number of crescents? So if the number of more than 75, you just you keep the immunosuppression minimum because this patient is not going to gain the kidney back. But if the number of normal glomeruli is also significant, if the number of normal glomeruli is more than 25, 5-year kidney survival is more than 75%. So that is good. So you have to look at the number of crescents as well as number of normal glomeruli. Both of these are predicted. And even if 10% of glomeruli are normal, still it means that they may come off dialysis. So normal glomeruli is of great significance in this. Then the interstitial infiltrate is actually predictive of poor response. The IFTA is not predictive because IFTA by the time it develops it's already too late to make any predictions. Of course, creatinine more than 500, but that is based on the original trial. And if you see the original trial also, creatinine more than 500 did not make much of a difference. Requirement of dialysis is the key thing. Once you require dialysis, there are hardly anybody who comes off dialysis. And lastly, oligonucleotide presentation, almost same correlation as the requirement of dialysis. So, some of special clinical situations, one of the de novo anti-GBM after the transplant of Alports. So, this can occur in 5 to 10% of Alports. Now, this is a different entity from antigen disease because here the antigen is against the alpha 5 NC domain and not against the alpha. Therefore, the anti-GBM antibodies will not be detected in the blood because that's not the same as you have to use a different assay and that assay is not available commonly. And this usually develops very early and almost always leads to graft loss. The problem is that you do a repeat transplant that will recur in the repeat transplant also. So, probably you may have to try some strategies in order to prevent that. And one of the predictive factors is the large deletion disease. So, that may be one of the predictive factors. But just because the large deletion does not mean that these patients should develop a disease in the anti-GBM disease in the graft also. So, it is probably something to keep your antenna out for, but otherwise, not otherwise. And what about double positive? We already talked about that. So 10% of ANCA vasculitis will have double positive, but 50% of anti-GBM will have double positive. So if you have an anti-GBM, you are more likely to have an associated ANCA antibodies also. So probably one of the mechanisms stated is that the ANCA is already present in these patients. It produces glomerular trauma and exposes cryptic antigens, and that is why you get an anti-GBM disease. So that is an explanation. And again, the anti-MPO, we already talked about that. And epitope spreading is one of the mechanisms by which this occurs. So the important clinical points are that they usually behave like anti-GBM disease and have to be treated like anti-GBM disease. But the important point is that they may come off dialysis better than those with pure anti-GBM disease alone. But same time, they may relapse unlike anti-GBM disease, like an ANCA vasculitis. So they have the behavior of both. And some of the behaviors are good, some of the behaviors are not good. So we have to select whichever we like. The drug-induced anti-GBM disease is also coming up. One of the things, alemtuzumab has been shown to produce anti-GBM disease, anti-CD52. Why it does is not known, probably because it suppresses the regulatory T cells, one of the mechanisms proposed. So there are a lot of other drugs which suppress regulatory T cells which do not produce. So there must be something more behind it. TNF-alpha antagonists, so infliximab, they have been shown to develop, some of them have shown anti-GBM disease. So the mechanism again is not known and why it occurs because experimental models it actually prevents anti-GBM disease and treats anti-GBM disease. Then immune checkpoint inhibitors they are popping up everywhere in nephrology these days and they also rarely cause anti-GBM. Fortunately, it's rare. More common toxicities are acute kidney injury and acute interstitial nephritis. All COVID vaccines are very rarely, all the vaccines, the Moderna vaccine, Pfizer vaccine and the AstraZeneca vaccine, all of them have been shown to produce some little bit of anti-GBM disease. But you must realize COVID itself is a presperator for this. So we do not know which is the actual event. And then membranous nephropathy. So we've been talking a lot about membranous nephropathy today and membranous nephropathy also can predispose to anti-GBM disease. So one of the mechanisms proposes because of disruption of the GBM secondary to the antigen antibody reaction which already occurs membranous. And usually you see a membranous producing RPRF. So many times you have to go maybe due to the nephrotic syndrome, maybe due to the diuretics, etc. But sometimes it can be due to anti-GBM disease. And the treatment is by you give Plex and you also give rituximab. The rituximab treats both. So that may be one of the ways by which we treat. And the thing is that these patients will have an anti-GBM antibody positivity also. And lastly, about atypical anti-GBM disease. So this entity was described by Nasser and others about 10 years back. And this was the largest series, 20 patients. So it's defined as linear IgG on IF, but there is no crescentic GN. Usually the pathology is like a mesangial-proliferative or a mild or focal proliferative glomerulonephritis. And there is absent anti-GBM antibodies in the blood. And the course is not like that of an anti-GBM disease. It's a prolonged indolent course, more like a chronic glomerulonephritis. and many have light chain restriction. But the authors have said it is not like PGMNID, which I do not understand why it's not like PGMNID, because it looks more like it. But whether it can be treated with clone-directed therapy is also not clear, because it has not been stated. So maybe due to an antibody which is unable to fix complement, or it's unable to recruit inflammatory cells, that is why it is presumed that this is behaving like this. But treatment is absolutely unclear. There are only small series. So probably the treatment is advised is only anti-proteinuric therapy at this point of time. Maybe because if it is only lambda isotypes person, maybe we can try some anti-plasmacell therapies or rituximab. But we don't know. There's no actual treatment. And lastly, is our own experience due to MRD department in my hospital, which has suddenly gone to sleep. I have not been able to cover my patients, but I have been able to get these 10 patients in this, and you can see that doesn't look very good. So out of these 7, 3 have died, and some of them are quite young. There's 35-year-old and 32-year-old. So both died, and many of the renal recovery occurred in only 4 patients out of 10. One was lost to follow. 4 of them we have transplanted. One of them retransplanted. He had a graft loss due to rejection, and we did a deceased donor transplant afterwards, and he's surviving that. But generally, you can see the prognosis is not very great in this disease, despite all the treatment that we have done. So it reflects the general dismal and gloomy prognosis of the disease. So finally, I would like to say you should diagnose it early, and probably as soon as you diagnose, you should be able to use flex, cyclophosphamide, and steroids. Early treatment is the key. If you are able to treat early, you may be able to get the patient off dialysis, and probably renal function might improve. But if you delay it, then it's just going down the drain. And lastly, if there is lung hemorrhage, you should be very proactive in treatment, and they will die of lung hemorrhage, and many of them require ventilator therapy, and once you go on ventilator, prognosis is even worse. Thank you very much.
Thanks, Satish. Great talk. Do you get false positive anti-GBM antibodies? And secondly, whether the drug-related anti-GBM disease, like you have some drugs which give you false positive lupus antibodies, do you get false positive, or it actually leads to?
I don't think there is any false positivity for anti-GBM, but especially because we are not checking it routinely. We are checking it in a situation where we are expecting an anti-GBM antibody, and there when it is positive, it is always positive.
The drug-related anti-GBM is a disease, or it's just a report?
It is actually an association. So these drugs are all new. If you look at the except the TNF inhibitors, the CD52, actually the alemtuzumab was used in multiple sclerosis, and that is where some of the patients have developed anti-GBM disease. So we don't know the mechanism why it is, and even this TNF inhibitor is extremely rare. As well as a rare disease, and even as a combination of drugs, it is quite rare. Questions?
Small clarification about why atypical anti-GBM is different from PGMNID. In PGMNID, the deposits are granular. So granular IgG and C3 and lipase. In an atypical anti-GBM, this is a linear IgG. Yeah. So that is the, like two completely, under the microscope, we have completely different diseases. So the only common denominator is both having a lipase. And only 10% of atypical anti-GBM have a lipase. They still have an atypical anti-GBM and have a polymerase.
Thank you. Thank you for the clarification.
Sir, I have a question, sir. Sir, if at a month after starting immunosuppression in a patient who is biopsy proven almost 100% cellular recent with anti-GBM disease, so there is no possibility of transplant in that patient. Patient is on dialysis. Would you still continue immunosuppression? Antibody titer is high. There is no lung involvement. Would you continue immunosuppression? What is the clinical practice?
Yeah. So this decision to continue immunosuppression or stop depends upon the clinical status of the patient. Say a patient is having lung hemorrhage, present lung hemorrhage, you would like to continue for some more time. The patient is not having any lung hemorrhage, is not having any symptoms like this, then only you find out the biopsy there is 100% presence, and you are following for 1 month, so there is no recovery. Why do you want to continue? Then stop the immunosuppression. So generally, my practice, I just stop it. One of the patients who actually presented with end-stage kidney disease, and we did the biopsy because kidney size is normal, and that showed 100% crescent, and all were fibrous crescent. So we didn't treat at all. So we didn't give any treatment. We just took the patient for transplant after a few months.
Sir, in continuation with the same question, there is a subset of a patient who don't have lung hemorrhage but other features of anti-GBM antibodies. Is there any difference between the acute treatment of both of these subgroups?
No, so if there's an acute presentation, we should treat aggressively because you can try and salvage the kidney. Now, even though you know that the dialysis patients do not recover, in that study, the 2 patients recovered. So, if it's a young patient, if the biopsy is showing it's a recent onset symptoms, and you know that the disease is not yet advanced, it's always worth giving. You give them steroids, give them cyclone, give them flex, wait for 1 or 2 months and see. If there is no recovery, then probably there is no point in continuing. But if there is some amount of recovery, it's worthwhile. So I would say, but this older patient, 70 years, 80 years, will still be.
The question is that in the recent era, the role of plasma exchange in different scenarios, this is one of the main indication for plasma exchange. Now, ANCA-associated vasculitis is also going away from the plasma exchange. So that is why I asked you the question, what is the role of plasma exchange in without pulmonary hemorrhage and with pulmonary hemorrhage?
Yeah, with pulmonary hemorrhage, definitely there is indication of plasma. Without pulmonary hemorrhage, also, if there is a the anti-GBM disease presenting, you should do flex. So if it is early, say the creatinine is not yet gone, you are going to try and salvage the kidney, probably kidney may completely recover also. Not completely, at least partially. Even if the patient is on dialysis, even if you have 1% chance, it's better to try in because recovering kidney and the kidney going in for the chronic dialysis transplant is actually two different things. So I would say treat them upfront. Even older patient, maybe you may temper your immunosuppression, maybe you may give rituximab instead of cyclophosphamide. That may be one of the ways to do it. But still, if the patient presents early, whatever the situation, we have to do flex.
Because of broad process of disease, the patient is dialysis dependent with no systemic features of ANCA. So how long to go about the immune suppression?
Yeah, double positive. Yeah, double positive. I think the maintenance immunosuppression is important. Double positive. In this, there is no maintenance immunosuppression. It's all an induction and the continuation of the induction. That's what you're doing. So maximum is steroids for 6 months. That's what is common. 6 months is the ultimate. By the time, I think by 3 months, you will make a definite decision whether to continue or not. But in ANCA positive, it is different. When there is ANCA, you should treat like ANCA in the chronic long. You should be continuing.
Dialysis dependent.
Definitely.
Especially there is a second talk coming now. But let's thank the speaker and please present the